All right, wanted to take a moment to tell you a little bit about who I am and why this topic is important to me. I am Kelly O'Dare. I'm a faculty member at Florida A&M University in Tallahassee, Florida, but I'm also the founder and the director of the Second Alarm Project, which is a program that started back in 2019 after Hurricane Michael came through the Panhandle area and caused a lot of destruction. We received our first grant to start the program proper in 2019. And we'll tell you a little bit more about the Second Alarm Project, who we are and what we do in just a moment as well. I have a PhD in social work. I also have a clinical MSW, although I do not maintain a license and I do not practice. I leave that really important work up to the experts, such as many of you on the call today and my colleague, Michelle, to do that work. I'm very fortunate to be able to surround myself with people who have a very high level of clinical expertise. And so I don't do that work myself. I do an awful lot of behavioral health navigation and some crisis intervention and other things like that. But I do not do therapy. I do not do counseling. I also have a master's degree in public administration. And really the blend of those two is what led us to develop this program, or to have the desire to do this program. So that's what kind of gives me the credentials to do this work, but it's not the why of why I do this work. And knowing our why is important, particularly when you're doing this kind of work that can bring on a lot of burnout and a lot of compassion fatigue. So remembering our why is important. But I grew up in a first responder household. My uncle, Sean O'Dare, was a firefighter with Miami-Dade County Fire Rescue. And my slide is not advancing. There we go. That's my uncle and myself when I was a baby. Obviously, he gave his life in the line of duty in Miami-Dade County. And so that really impacted my career trajectory even more than I knew at the time. I didn't realize it till just a few years ago how meaningful that was to me. I'm also married to a firefighter. Our son was a cadet in the fire service for a while. So this is definitely very much interwoven into the very fabric of who I am, is serving this population. And this last picture just really reflects our why. It's serving the individuals and their family members who are in the first responder communities and who are doing this work. And I'm grateful every day to do this work with these first responders and their families. And with that, I will invite our wonderful lead clinician, Michelle Rabine, to tell you a little bit about herself.
So good morning. Yep, my name is Michelle Rabine. I'm a licensed mental health counselor. I also have my master level certified addictions professional certification. I've worked with trauma for a very long time, many years. It wasn't until maybe the last 8 years I started specializing with first responders, and I started at UCF Restores, which is a trauma clinic on the UCF campus in Orlando. I'm very grateful for my experience there because the directors of that clinic put a lot of focus and attention on how to provide the right kind of treatment for this specific population, first responders and military. And so it took me from what I learned in school and through my internship, and it skyrocketed me to another level. And I will always be thankful for that, because I see where, if I didn't have that experience and additional training on the job, I would not have become as effective with the clients that I see today. And one of those things is, going back to the basics, and that's what I want to talk about, today throughout the slides.
Thank you, Michelle. Really looking forward to that, and so grateful for all of the experience that you bring to the table and have helped us with our program to make it what it is today. So All right, just want to tell you a little bit about the Second Alarm Project, who we are and what we do. As I mentioned, we kicked off formally in 2019, although I had been doing quite a bit of research with first responders prior to that in my previous faculty position in the Escambia County area. We had a chief in that area who approached us and said, hey, do you guys know anything about this whole PTSD, thing? It's still kind of emerging right now. It's definitely gotten a lot more attention in the last 5 to 8 years. But at that time, this type of work with first responders was largely just beginning. And so we said, well, sure, we know quite a bit about PTSD, but we don't know a lot about this with first responders. And we certainly don't know anything about it with your first responders. So let's get in there and do some research and learn as much as we can with what's going on in this community and the problems that you're seeing and doing a needs assessment. And what we found was really shocking. Unfortunately, we're going to talk some more about that this morning. Really high prevalence rates of not just PTSD, but other types of issues as well that we're going to talk about. And then a real lack of resources. So you combine a high level of need with a lack of resources, and it's just a recipe for catastrophe. So fast forward a few years, I was doing some work over here in this area, and
Seattle gets. We're talking about hot summer,
I'm
good back,
getting
low
some
90s, only
feedback.
20% rain chance on.
Okay, that's better. Thank you. So fast forward, we had all this research that did a great job of framing the problem and putting the problem into context, but we still didn't have a lot of solutions. And so I set out to find some grant funding to develop and implement some solutions specifically for this population and specifically based on the needs assessment and the research that we had done and what we learned. So in 2019, we kicked off the Second Alarm Project, and we try to make it as comprehensive as we possibly can. So we want to be implementing services and supports and resources all the way from recruits and cadets. As I mentioned, my little one was a cadet for a while. So cadets and explorers are a group that is very important to me, all the way through retirement, including families, and looking comprehensively at providing education and training, peer support, capacity building, providing linkages to services if and when they're needed, and that bigger picture of looking at culture change. So I just mentioned this next slide really, and sorry, I'm having a problem advancing slides. There we go. So this is what we do. And we really have a big emphasis in our program on community-based capacity building, meaning that we want to go in and we want to work with communities and we want to work with first responder organizations and really infuse everything that we know, all of this knowledge that we've gleaned and all the ways to build a comprehensive program to take care of their people. We want to be able to build that into what these organizations are doing on a day-to-day basis. So that's really a big part of who we are and what we do in our mission, is to capacity build and to provide technical assistance to communities and organizations who want to do this work. We also provide quite a bit of training and education, such as the class that we're doing today. And we do quite a bit of peer support and critical incident response in the responder communities. And we've had great success, and we're grateful again to our first responder communities, to the responders themselves and their families, working hand in hand with us to develop this program and to make the resources available within their communities and to each other. And we just look forward to continuing to do this work and to continuing to making more partnerships and forging more relationships in communities with individuals such as yourself who are on the call today. One of our primary projects here as of late has been building this BHAP toolkit. A BHAP is a behavioral health access program. If you've been on our calls before, you've heard us talk an awful lot about the BHAP and why it's important. But it is just another resource that we wanted to make sure we made available to first responders and communities to be able to help themselves in addressing the needs that they see going on with their responders and their families. All right, and with that, I would love to open the floor up because we would like to know a little bit more about who you are, who's on the call today. And I think we have a fairly small audience today, so what I would love to do is if you would just unmute, and I think I will draw on my professorial training here and call on people. That way we don't have a lot of people trying to unmute and overlap at once. So I'll call a name, and if you would just mind introducing yourself, telling us who you are and what organization you're with, and also maybe a little bit about what you hope to get out of this training today. That'll help Michelle and I maybe direct some of our conversations around what the group is really hoping to get out of the conversation today. And I'll put these learning objectives. Here's kind of what we have planned, but we want to meet you all where you're at. So maybe you're hoping for something a little bit different, and we can take some time to speak to that today. So I've already introduced all of our team. I'll go ahead and toss it out to the rest of the group and call on Brandy. Brandy, would you unmute and tell us a little bit about yourself? Brandy Thompson.
Sure. Yeah, my name's Brandy. I'm a mobile crisis response team counselor with SMA Healthcare in Volusia, Flagler County. And I'm hoping to get out of this class just some more interventions. We're getting an increased number of calls for first responders in crisis. So I'd like to just know how better to provide immediate services for them.
Thank you, Brandy. That's fantastic. And it is absolutely needed. And not to get off too much on a tangent, because we're going to talk a lot about this particular topic next week, if everybody is available and wants to attend the workshop next week. One of the really important pieces that we've learned about with crisis services for first responders is being able to make that linkage from the crisis situation to either an inpatient crisis stabilization facility or a residential facility, either, through the least preferred mechanism, which is a Baker or Marchman Act, or a more preferred mechanism, which is a voluntary admission. What we found we had to do here in the Panhandle was to establish some MOUs with some intake facilities for them to do crisis intake that looks a little bit different for first responders than the general population. So I'm really excited maybe at some point to hear from you if you guys have been able to do that in Flagler, Volusia, if there's any participating centers or facilities over there that have been willing to take that extra step to set up a program that's specific for first responders. We were very surprised at how often we have to use that after we've have it established now. It's one of those resources you hope you don't have to use, but you're really grateful that it's there when you need to use it. So I'm so glad to hear that you're doing that work. Thank you. Okay, it looks like Patricia.
Hello, good morning.
Good morning.
I'm Patricia Doubles, and I am with the Department of Children and Family in Miami-Dade County. I'm honored to be here with all of you this morning. Well, what I really want to learn, because it was a surprise to me that the first responder that had so much issues, and I am so thankful that I'm able to go through this training so that I'm able to learn and then to see exactly how we're able to assist totally and completely.
Thank you, Patricia. And I think that that's often a common response, is that we don't know that this is occurring in these communities until we know. So it really does take a perspective and approach like the one you shared, that willingness to learn to be able to make a difference. So thank you very much. Okay, Anna. maybe we'll come back to Anna. Anna will come back to you unless you've got yourself unmuted.
My boss is on the phone with me. I'm sorry. Hold on.
Okay, I'm having a little bit of a hard time hearing you too.
I said my boss is on the phone with me. I'm sorry.
Oh, no worries. Okay,
Okay.
we'll come back to you. Sure. Okay, Janice. Welcome back, Janice.
Good morning. So, my name is Janice. I'm a licensed mental health counselor. I'm a certified in trauma as well as in providing teletherapy services. I work in the Marion County school system as a school intervention therapist. So I provide mental health therapy to a specific group of kids in the school system. I'm also in private practice. And in private practice, I do a lot of work with trauma. I am in the process of wanting to just fine tune a certain niche. And I found that there are people in different types of leadership positions that present differently when it comes to trauma and anxiety and depression and that kind of thing. And so I'm interested in just becoming more culturally competent in the area of trauma and first responders, and learning specific interventions and techniques that are specifically effective for that population.
Wonderful, thank you. And I'm fairly certain you've said this when you've introduced yourself before, but I just picked up that you're in Marion County, and we've been doing quite a bit of work with the fire service there in Marion County. They've had some pretty significant events happen there, and not a lot of resources in the area. So I'm super grateful to hear that you're interested in this population and that you're right there in Marion County. And we would love to get you set up to be a provider on Redline Rescue. I don't know if we've talked about that on any of the calls that you've been on, but it's kind of a network of people such as yourself who have put in the effort to become culturally competent. That way, when a first responder may need to reach out for services, they can find you, and it has even a way to map where people are. So if somebody was in Marion County looking for a culturally competent provider in Marion County, it would list you as a resource on there. So we'd love to talk with you more about that if you're interested.
Definitely, I would love to be a resource, definitely.
Thank you. And that goes for anybody else on the call too, not just for Janice, any other mental health providers who are interested in that. Maybe towards the end, we can talk a little bit more about that. And, again, just my thought with us with the issues in Marion County right now, they really need some resources. So that would be fantastic.
Okay. Lord, thank you.
Okay, Kim, good morning and welcome back.
Good morning. My name is Kim DeLillo, and I'm a licensed mental health counselor, a registered art therapist. I am a trauma therapist, and I'm also the licensed clinical program supervisor for CHS for our brand new program, the First Responder Peer Support. And I'm here to learn as much as I can about everything. And I really appreciate, every time I'm in one of the trainings with you, Kelly, I'm learning more and more stuff. So I really am very grateful for this series.
Well, thank you, Kim, and we're grateful you're here, and we're grateful for the work that you're doing up in another area that is in need of resources. So thank you so much. All right, Louis, nice to see you this morning, sir. How are you? Oh, I don't know if maybe, Louis, are you having mute issues? Okay, we'll come back to you. All right, Thomas.
Good morning, everyone. Happy Friday. So me and Brandy Thompson actually work for the same agency, SMA Healthcare. We are currently in 6 counties, so Marion, Citrus, Volusia, Flagler, St. John's, and Putnam. I am the director for the Access Center in Flagler County. When I came here, which is not even a year yet, I was approached by the county rescue and fire department. And this is something that they are trying to launch. So we have a first responders initiative that is very, very early in its infant stages. And so I am here to pick your brain, to pick anybody's brain. I'm glad to see Brandy on here because she is a vital part of that process from the CRT. We do have a receiving center for CSU. We are actually expanding where we are building one here in Flagler County within the coming years. Just passed, the governor just signed it, so I'm amen to that. I'm happy. So with this, I am hoping that we can assist our first responders. So I am a current first responder myself. I'm law enforcement, and so I understand the need. I didn't have anything like this when I was going. When I was working in law enforcement, and my life may have been different if it was available. So kudos to you guys. I appreciate everything that you're doing. And again, I'm just here to pick your brain.
Thank you so much. Well, we are happy to share information. Glad that you're eager to receive it. And really, you bring such a valuable perspective being in the first responder community and then now doing the work that you do. So it's always nice to hear when people come into the behavioral health realm with the first responder experience. I think it's invaluable. So thank you for that. All right, Valerie, good morning.
Good morning. I'm Valerie Duquette. I'm the director of the care center in St. Johns County at Flagler Health Plus. It is a brand new program in our area. It's a year old. We are a fully functional registered as a central receiving system. We are building all of those services as we go through. So we do perform assessment, intervention, intake, and referral services. So we're a short-term kind of bridge program to help people kind of get those immediate services and interventions and then help them move on to a longer-term provider. So personally, I have a lot of friends and family members that are first responders throughout the various agencies and levels of care there, including emergency rooms, on patrol, out in the military, all over. So this is a population that's very near and dear to my heart. And I do not practice privately, but I do a lot of resource navigation for our local first responders and for the people in my personal life. I do some pro bono work for folks when they are referred to me because they don't know what else to do and need some additional assistance while they're navigating to find the appropriate programs and systems. So I try to jump on as many of these trainings as my schedule will allow, just to kind of keep current and get as much information as I can to make sure that we're always pointing people in the right direction.
Thank you, Valerie. All right, Anna, we'll pop back over to you if you're available now.
Can you hear me?
We can.
Okay. I'm Anna Ficarelli. I work right now for the Department of Children and Families as a quality assurance reviewer. So we review all the cases for the state of Florida. But prior to moving to Florida, I was a mental health counselor for juveniles and their families in New York State. Then you move here and the requirements are different. So I came down here and worked for, well, it was HSA and then Chrysalis Health. The system down here for juveniles is definitely different than New York State. So I ended up being a CPI, which is, I know people might not consider it a first responder, but we do walk into some situations that law enforcement even say they wouldn't go in without guns. So right now I review the cases, but I feel like it's important just to know some other skills because you're dealing with these people now that go in every day like I used to. And as a supervisor, you're monitoring these cases, but I just love trainings and I miss the mental health aspect because I'm not doing it down here. So I saw this training and I was like, oh, I just want to learn whatever I can. And
Thank you, Anna.
I used to work for Orange County, but now I do the whole state. So I'm just based in Seminole County, but.
Great. Thank you so much. All right. It looks like we have somebody, first responder support. All right, and maybe we'll bounce back over to Louis. If you want to unmute and say hello. Okay, well, I think that I went through everybody. If I missed you, feel free to unmute and say hi. If not, if you want to type in the chat, that's fine too. If you'd prefer to do it that way, please feel free to do that. And again, feel free to type questions or comments in the chat as we go through, and we'll go ahead and keep on rolling here. All right, so we're talking about first responders this morning, and I heard some people, say that they had different definitions of first responders, and that's actually very common. There isn't one single working definition of first responder that we found. Even in state and state statutes and federal law, there can be a lot of differences. So at the Second Alarm Project, we've kind of adopted our own working definition of who first responders are and who we serve as far as who's eligible for our services. And in some ways, we align with the Florida statutes on who is a first responder, but we also add a couple of categories in that do not have statutory designation in the state of Florida, but that we think are important to include. For a few reasons, the literature supports it for one, but practically it's important as well. So these are some of the categories that we serve. We also include retirees and cadets in there, as well as family members in our services. And there are some instances where we do include non-sworn positions. And again, that's been just based on our experience and on our need. But it does get a little challenging sometimes because there can be a bit of mission creep. We get great feedback and conversations frequently about the need for these types of resources and services in the healthcare fields. Nursing, physicians, other people who work in emergency rooms. We even had a great call one time with veterinarians because evidently they have a high rate of deaths by suicides and moral injury that happens in their professions. We had a couple of calls with about morticians and people who work in funeral homes. So I think overall, it speaks to how important mental health is, behavioral health is, wellness, resiliency for the human experience overall. It just so happens to be that our expertise and our program is focused specifically on these types of first responders. So I've learned a few things about the first responder culture over my time working with the profession and being a family member of the profession. So these are just some of my observations. And of course, not all of these things are true for everybody all of the time, but by and far, we find that a lot of first responders share many of these similarities or many of these characteristics. They do choose a job that most people cannot do. And over the course of doing that work, they tolerate what is intolerable to others. A first responder may see more traumatic events in one shift day than I hope to see over the course of my entire life. I'm sure I may hear about it a lot, but participating in a response to that situation firsthand is very different than hearing about that situation. Although, secondary traumatic stress can happen from hearing about those things, or vicarious trauma. What we see in our responder population from experiencing these things firsthand, day in, day out, is that it can create a primary traumatic event. It certainly doesn't mean that every traumatic event that a responder goes on is going to cause some type of emotional or psychological distress. What we've seen is that actually most of them do not, but there oftentimes are calls that will just stick with a responder. If you talk to any first responder, those of you who are on the call today that are first responders, you may have those calls that just kind of stick out over the course of your career as having been particularly memorable, or that have been particularly challenging. First responders have a front row seat to some of life's ugliest moments. they're really a culture of fixers and a culture of problem solvers. So when they roll up on a scene, they have to size up that scene and decide how they're going to intervene or mitigate to make that situation better than what they just rolled up on. So it's kind of inherent in them to be problem solvers and fixers. They're also pretty inherently resilient. Another thing we like to talk about with our first responders when we go out and do trainings is that we aren't coming in there to say that they're all traumatized and that they all need therapy. Actually, we're kind of saying just the opposite, is that they're a tremendously resilient population with a lot of strengths. And just sometimes they may need a little bit of assistance in working through some issues that may be job related, or they may not even be job related. It may be stressors off the job at home with family and finances and just regular everyday life that are causing problems for them. So we really want to emphasize when we're working with the responder population, that strengths-based, solution-oriented approach. There's a very strong brotherhood and sisterhood, which is a huge strength that we want to leverage. And we do that through the value of peer support. And we can also use that to promote some of this culture change that we're trying to do within organizations. And we also find that there are a lot of type A personalities with first responders, that alpha male, alpha female mentality. Again, it's not always true for everybody, but these are largely characteristics of first responders that make them really good first responders. When you talk with this population and you ask them, hey, why did you want to become a cop? Or, hey, why did you want to become a firefighter? They'll tell you about it's a passion, it's a purpose, it's a mission. Some of them are legacy first responders. Their great grandfather was a firefighter and everybody down the line in their family was a firefighter. So that's why they wanted to be a firefighter. So it's a calling. I don't know that you would be able to do a job that's as demanding as say a law enforcement officer if it wasn't a calling and a passion and a commitment. I've never yet heard a first responder say, I do it for the money, or, I do it for the fame. Like those are typically not the reasons that when you ask a responder what their why is, it comes from a very deep place for them. So being able to tap into that when we go out and work with this population has been incredibly important. Something that we talk about when working with this population is repeated exposure to trauma or potentially traumatic events. And that potentially traumatic event is a very important way to describe it, because not every really bad scene is going to be traumatic for every responder who responds. So it's okay to be okay with something, but it's okay to not be okay with something as well. And so we want to be sure that we are kind of defining this as that repeated exposure to trauma, or that primary trauma that first responders may be experiencing on some of these calls, as opposed to thinking about it as vicarious trauma or secondary trauma, because those need to be defined and really approached and treated if somebody needs treatment a little bit differently than experiencing a primary trauma, or as you clinicians on the call might have learned to talk about it as and Michelle will talk about this, a criterion A event. So a secondary trauma or a vicarious trauma may not meet the definition of a criterion A event, whereas repeated exposure or this accumulation of trauma over time will meet some of those diagnostic criteria. And as we talked about, first responders have to be ready to do this every single day. Over the course of their responsibilities, they have the potential to see a lot of very challenging things. Severe human suffering, badly injured people, pediatric calls. Of all the calls that we work with responders through, the pediatric calls seem to be the most challenging. And then the individuals who are there who are not necessarily injured or who are not necessarily patients, but they're the bystanders, they're the witnesses, they're the family members who are very highly distraught on scene. And, you know, there's no social worker there with the first responder. There's no mental health counselor there with the first responder to be helping to manage the family of this child who is just, you know, drowned in the pool while the responders are trying to do their work. So there's so many different elements happening on a scene that can be very challenging for them when they're trying to do their job and they're trying to stay in work mode and not shift over into feelings mode, because we don't want to take a first responder out of work mode and shift them into feelings mode in the middle of a scene. Maybe after, when we're trying to debrief and decompress, but not when that is occurring. And so I'm fairly certain Michelle's going to talk a little bit about this more during her part, but this is one of the values of starting with the basics, which is, if you want to work with this population, doing ride-alongs, immersing yourself in their culture, riding along, so that way you're actually there on a scene at a child drowning, and you can see firsthand what it's like to perform CPR on a young child for these men and women while they're, you know, attending to distraught family members, and while law enforcement is on the scene trying to make sure that, you know, any evidence that is there needs to be preserved. And there's just so many things and so much of a value that you can get a benefit from riding along. So any mental health provider that wants to do this work, that's really just step one in becoming culturally competent, is doing as many ride-alongs as you can with the fire service, on an ambulance, with law enforcement, sitting in a dispatch center, listening to the calls as they come in, and seeing how those dispatchers have to take those calls and respond to those calls. It really does give you a way better understanding of the work that these individuals are doing. Are there any questions or comments? Michelle, you have any follow-ups on ride-along, since we're kind of already touching on them there?
Yeah, I think that if there's anything that a clinician can do, not only to bridge the connection between counseling services and the first responder community, is to do the ride-alongs. I think if I can tap into even how a clinician sees themselves, I don't know about anybody on this call, but, you know, when I realize I've needed help in the past, calling for counseling is very tough, because I find myself in a role that also helps people. And so therefore, when I need help, I question my own abilities. And so it's not the same, but it certainly is an overlap. And so what I have discovered is that if I spend time, and my typical time frame is, you know, 3 to 4 hours max, although I have had the opportunity to do full shifts and even stay overnight, which I think is even more helpful to see what it's like to get all those calls during the night and how they manage themselves between calls, trying to get sleep, or just trying to stay awake because, you know, they're not sure what to do. And then of course, knowing how caffeine will affect them. So a lot of layers going on when you are in a ride along. You see a lot of behaviors, a lot of interactions. And then it's all about the background knowledge, how things are. And a crew that is open to your ride along visit will sit and educate you. They want to educate you. And the only thing that I'm doing when I'm on a ride along is I'm just here to learn. I'm here so we can be familiar, because if anything bad were to happen, because part of my job is to do critical incident response, it's not the first time they're seeing me. They don't want to see new faces when they're in the midst of heightened stress. They want to know that person. So again, buy into your presence in their departments is crucial. And the only way that I've found that's highly effective is to do a ride along. Now, there's a lot of rules and a lot of things to learn. You are a guest in their house. If any of you have ever heard, and I don't know if I'm going too much into this right now, Kelly.
No, it's perfect. I think it's a great time for it.
Okay, I would encourage every clinician that wants to get on Redline Rescue to seek out the Florida Firefighter Health and Safety Collaborative, and I might have said that backwards, but the collaborative is an essential resource to allow you the background training. It's a 2-day experience, and they do offer CEUs, so we all need those. And what it involves is a day of education and a day of actual training for you. So in most situations, you'll get to wear bunker gear, understand what it's like, you know, how they go into a fake burn. So they'll have their training facility or a training facility available. And I never realized that firefighters didn't stand up when they're attacking a fire. So again, you know, just learning the fact that they're crawling through, most times they're crawling through the structure, and how they crawl through, and how they drag the hose, and how they recover people inside, and then what their tactics are. It eye-opening, and not only that, how they do a scene size up. Again, following, you know, the crew as they come up onto scene. They don't run out of their trucks and just, you know, crash in on the victim. They do a scene size up. They stop, they take a look at what's going on. And I was sitting next to a lieutenant at, you know, my beginning encounters of this, going, shouldn't we hurry? Shouldn't we get there faster? And, you know, it's not how it works, because they have to go in and they have to be focused and purposeful. And the only way to do that is to take a step back. And so you just learn a lot of nuances being on these ride-alongs. So again, I highly encourage every clinician on this call to, again, look up Florida Firefighter Safety and Health Collaborative. They have a website and it's a great, I did their training twice and I do it again. And every time that they put on a training, a lot of times what they have you encounter is different, you know, from an MVA to structure fire to MCIs and all the different types of things, you know, and they even let you use their tools. So just kind of cool.
Yeah, thank you, Michelle. Maybe it would be helpful if Leah or Brandy would be able to drop the links to those in the chat. So the link to the CAP training, I actually think it's on UCF's website now. It may still be on the Safety and Health Collaborative's website, but the link to the CAP training for both fire service and for law enforcement. So historically, this has been done for the fire service, but we have been working really hard and waiting for a while now to get this out for law enforcement and for dispatch as well. So there are a couple of law enforcement opportunities. They also did one, it's probably been 5 or 6 years ago now, where they did an active assailant, an active shooter drill, more for the law enforcement side, and had the clinicians come in to an active shooter drill just to see what those law enforcement officers encounter and go through in a situation like that. So yeah, so just a great opportunity, and we'll drop both of those in the chat. So if you're interested, you can participate in those. All right, I want to talk a little bit about the context of the problem. I spoke a little bit about this earlier on, how we've been doing some research with first responders. And I think it's important, well, it's imperative if you're going to be culturally competent, but also providing evidence-based practices or evidence-based treatments with your responders, is that you have to be doing an appropriate assessment, or you have to be doing an appropriate diagnosis. So Michelle's going to spend some time in the second half talking about how incredibly important that is, especially with this population, to be using an appropriate assessment tool to look at some of these mental health conditions. You know, oftentimes responders will come in with symptoms and they'll be subclinical on some of these screeners. Now I'm kind of getting off into a tangent, but it may be worthwhile. So they may be having, serious distress or concerns in activities of daily living and not being able to function and calling out sick to work, but they will not score high enough on, the PCL5 to have a diagnosis of PTSD. So Michelle's going to talk a little bit more about why it's so important to be using the appropriate diagnostic tools. Kind of taking a step back from that, when working with an individual client, what we did initially in our work with this population was to look at them overall, what was going on more epidemiologically as far as prevalence of mental health concerns with the responders that we were working with. And to date, we have about 12 or 1,300 first responders who have participated in our behavioral health survey. And that's comprised of the biggest category we have that has participated is the fire service, but we also have a significant number of law enforcement officers. We've looked at single cert EMS providers. What that means is in the first responder world, you can be dual certified in two responder professions, or single certified as one responder. It most frequently happens in fire EMS. They'll be dual certified as both a fire service member and as an EMS provider. Or there are some EMS providers who are also not firefighters, and so those are the single cert. We've even heard some really interesting examples where there will be really small communities, very, very small communities. I think this may be one example I learned about was over in Volusia. There's a beach community over there where their first responders are actually triple certified. So they're doing the fire service, they're doing EMS, and they're the law enforcement officers. So that's a really unique constellation of needs going on there. And then we have dispatchers who participated in this survey as well. And so the column there on the left is the category of mental health concern that we were looking for in the population. So we looked for things like PTSD and depression, anxiety, harmful alcohol use, and high suicide risk. We used reliable and valid screeners for each of these. So we didn't just go in and ask, hey, do you feel depressed today? Hey, have you been having anxiety? No, we used the PHQ-9 for depression or the GAD-7 for anxiety. So some of these same instruments that you would get if you went into a clinician's office were the ones that we used in our survey, but it was self-report. So that was one limitation, but we did get a lot of really good information here, and it put some things into context. The middle column there is first responders who would have screened in to being diagnosed on those screeners. And then the third column is just so we can kind of eyeball or compare to the prevalence of these conditions in the general population. So we didn't look at statistical significance there. That's important to note. But we're just looking at practical significance here in the differences. And as you can see for PTSD, about 23% of first responders would have screened in for a provisional diagnosis of PTSD on the PCL5 is what we used here, compared to 3.5% in the general population. So big difference there. I think it's important to note with PTSD, it's often times the concern that gets the most attention in the first responder community. There's laws, about it now. There's a lot of other things going on as well, but PTSD does get a lot of attention. Even in looking at our veteran and active duty populations, depending on which study you look at, generally speaking, veterans and active duty are anywhere from again, depending on the study you're looking at, 12 to 17% prevalence of PTSD. So we're talking here that our first responders are screening in provisionally at a much higher rate. And so that is problematic. And this would be a clinical score. So this isn't even those that are coming in with subclinical signs and symptoms of PTSD. With depression, 77% of first responders compared to 16% in the general population. Anxiety was at 39% compared to 5.7. Harmful alcohol use. We're going to talk a little bit more about this one because there's some important caveats here, but harmful alcohol use was about 37% compared to 8.5% in the general population. And we did only look at alcohol. We did not look at other substances in this particular study, just because it started to get very long, and we wanted to give ourselves the best chances possible to have first responders actually participate and take the survey. So if we started looking at, tobacco use or marijuana or, all the other substances that can be used, it would have gotten very, very long. And then that last one there, they're all concerning, but that one in particular is very concerning. That higher risk for suicide on the SBQR was the measure we used for that. First responders screened in at about 15.8%. So, that one always gets the attention of chiefs and leadership when we go in and do these presentations, because we can actually put a number to that and say, there's 25 people within your organization right now who are at a higher risk for suicide. That's problematic. And depending on what characteristics of the population you're looking at, it's significantly lower in the general population, 1 to 6%. Suicidal thoughts and behaviors, suicide attempts, and even completed suicides oftentimes look very different in the first responder population. And this is incredibly important with any clinician working with the first responder to be very comfortable with addressing suicide, talking about suicide, knowledgeable about suicide and what to do in some of these instances. Because what we found is that it's incredibly detrimental when a first responder starts talking about suicide to, jump immediately to an inpatient crisis stabilization or to a Baker Act. So there's a very fine line there, and Michelle's going to talk with us more about that in just a minute. But oftentimes when somebody has died by suicide, they will do a type of psychological autopsy, so to speak, to go in and look at what was happening in that individual's life, what were the risk factors, what were some commonalities that are across many instances of people who have died by suicide. A couple of these really stick out with our first responder population. You've probably heard, or you may have heard, that there's oftentimes a lot of family distress going on in first responder families, a lot of relationship difficulties, divorces, very high levels of divorce in both the fire service and in law enforcement, custody problems, oftentimes domestic violence is happening in these first responder families. So that's definitely a red flag. But another important one is this occupational or financial stress. So we hear frequently that the stress coming from the first responders isn't because of the traumatic calls that they're going on. It's because of what's going on in their work environment. Things like administrative betrayal and workplace incivility. Those are really causing first responders to have a lot of distress. And then the financial problems as well. A lot of the wellness models do not include financial wellness. And so we've really tried to focus on incorporating that, because financial distress does have such a strong correlation with death by suicide, and also all of those other mental health concerns. When we look at a strong correlate of any type of mental health decline, there is often a tremendous financial stressor there. And really, this biggest one that I want to point out when we're talking about the differences between the general population and first responders with suicide is exposure to suicide. So for the general population, exposure to suicide may mean that you knew somebody who died by suicide, or you have a family member or a friend who had a previous suicide attempt. But with our first responder population, every time there's a suicide or an attempted suicide in a community, these are the individuals that are responding to that scene. So it is not uncommon for them multiple times a month, multiple times a week, perhaps even multiple times in the same shift, that they're responding to a suicide or an attempted suicide. So it just creates this level of habituation to death and dying and ways to die that most of us in the general population don't have. For example, my husband's on shift right now, and he texted me yesterday morning that they ran a call to an attempted suicide that was a gunshot wound to the head. And so, you know, I can't even imagine what working a call like that, you know, induces on a person potentially psychologically. So it's just that level of exposure that our responders have that the general population doesn't. And Michelle, I'll leave this next slide to you to talk a little bit more about suicide.
All right, so I think one of the things that I focus on a lot, especially the first time I speak with an individual, and definitely the first time I meet with an individual, is to talk about suicide, normalizing that suicidal thoughts can be present. We all are susceptible to those thoughts. But just because a person says, you know, it'd be okay if I didn't wake up tomorrow, you know, we're talking more about morbid ideation. You know, it's passive, you know, it's got some transient qualities, it comes and goes. And it's when I hear that information, to me, I equate it with an increase in stress that's unmanageable. Sometimes if I'm trying to explain to an individual what might be going on, because of course having these thoughts is distressful in and of themselves for the individual, I will talk to them about the stress continuum. I will talk to them how it is to be at their baseline. I will talk to them about what do they do on a regular basis to manage stress. And from that conversation, I can draw out what their strengths and what their resources are. What do they rely on naturally? And a lot of times, you know, encouraging them to, and I use the term, play their movie to the end. Let's play this scenario out to the end. Let's really think about what it would be like following through. And all these conversations lead to, yeah, I really don't want to die. This is not about me wanting to die. And so, you know, you get stuck as a licensed professional saying to yourself, all right, what do I do with this? So the first layer of what we can do with this is first understand all these, you know, different labels that address suicidal thoughts. Is it morbid ideation? How passive is it? You know, and you know, from transient, from what situation, you know, to the other, what causes the connection? So one of the first things I do when I meet with a person is I do a full risk assessment. I ask them about not only historical, but current information that includes any psychiatric hospitalizations, any self-injury, which would be cutting, scratching, burning, punching, headbanging, anything that they purposely do to injure themselves. You can also take a look at substance and alcohol use as forms of self-injury. I also go even a step further with first responders to ask them about their own self-care while they're on duty and off duty. For example, do you clean your weapon? Do you clean your gear? And for most of that stuff on duty, it's mandated more and more. But sometimes they'll cut corners because they basically just have the I really don't care attitude at this point. And so that to me is more of a flag than other comments that they might make. I ask them if there's ever been an attempt in the past and what drives those stressors for them. I talk about the thoughts themselves. Tell me what those thoughts are. is there a plan? And then do you intend on following through with this plan? Because even if there's a plan, but it's a futuristic plan, I take it as I've got plenty of time to work with this individual. Now, the only reason why I feel capable in working with an individual that even as at this risk level is because I've also been able to have as a mentor and a past leader at UCF Restores, Dr. David Rosick. He's what you would call a suicide specialist. And through his research and dedication to the field of first responders and the concept of suicide, we've got a lot of opportunity to work with these individuals, because 9 times out of 10, these people are just trying to find an answer. Going back to what Dr. Roeder said about moral injury, sometimes those reminders of how a family suffers sticks with the individual very blatantly. That, again, repeated exposure to not only trauma, but human suffering. And that sometimes that human suffering can't be addressed at the time, because they're only there for a short amount of time to arrive at the call, perform their duties, and then they leave. And so a lot of times they don't see how the individuals recover from their incident. Are they okay? Did their family member die? Do they get help? How do they keep going? That is a big complaint. We want to talk about that. We want to talk about not only that it happens, but how often is this happening, and how intense is it when it occurs? And I will teach them a distress scale, and I ask them to talk to me in numbers, because numbers tell me a story much more particular than saying, well, it gets really bad. So just like assessments like the PHQ-9 and the GAD-7, I ask them to talk to me about their symptoms and numbers. What is the severity of this? How often is it happening? What promotes it? And what stops it? What keeps you from having it more often? And so knowing what their protective factors are, knowing what their risk factors are, is very important. Now, a lot of times, and as we know, in Florida specifically, many people carry weapons, and knowing where they're what access to lethal means and where these things reside. Is it pills? Is it their vehicle? Is it their weaponry? And the one thing is taking away guns and keys and pills, or that's not helpful, because just as we spoke on, these individuals run calls on hundreds of different ways to end their life. It's almost become normalized. And sometimes I'll even hear an individual say, well, that person must have been in high distress, must have been hurting very badly. And I'm glad they're at peace now. And the first responder who's had this situation normalized to them sometimes will also internalize by saying, I deserve some peace also. And so if they know hundreds of ways to end their life, taking away their keys and their guns, that's not helping. Stripping them of the things that they normally do is not helpful. What is helpful is creating a plan on how to distance themselves from these risk factors, from access to these lethal means, by saying, hey, look, while we work on things right now, what would it take for you to distance yourself from easy access? What would it take? So having that conversation also. So a lot of times my risk assessment takes quite a while. I dive into it and get almost every detail out of them that I can do, as far as knowing everything about time, place, and if they were hospitalized, was it helpful? What did they learn? and asking about gaps in between, since the hospitalization and current status. And if they don't have that, again, taking a look at their protective factors. Well, what keeps you from ever considering suicide as an answer to your problems? And the number one answer typically is that they have pets or young children that they would never trust anybody else to raise or take care of. Being future and goal oriented, there's something in my future I want to see or do. Those are really good aspects that say, you know what, you're struggling with these thoughts right now, but let's keep our focus on that. Let's keep our focus on the future, on your goals, on the fact that life is worth living and that there's a reason for it, and that struggling and hurting and all these other types of emotions that they're struggling with can be dealt with. We can work on that. And so providing that small essence of hope where there hasn't been one, even when an individual says, well, I've met with many therapists before, and they all say the same thing, but nothing ever changes. And sometimes my answer is, well, you haven't tried me yet. Again, having them understand that there's hope. There is hope. And then once you have them reeled in, and if suicidal thoughts are part of their assessment, then every single session we talk about it. Hey, what's your suicidal thoughts been like since we last met? How often are they occurring? How intense are they getting? What seems to trigger them, and what seems to end that thought cycle? And again, having evidence-based treatment that actually addresses the increase in efficacy through this type of symptom severity is important. And if it has evidence behind it, and if you are fully trained, not just informed, we don't want somebody that's just informed. We want somebody that's highly trained, that's done the supervision, and has had oversight in whatever modality that they choose. But I think suicide should be talked about. And I will reference Dr. David Rosick once again. I do know he does trainings on suicide that relate to first responders. He's somebody who I look to very often when I have a situation where I find myself, okay, I'm not sure if I'm doing right by this person, because one thing that I look at as a clinician is, am I being overconfident in my approaches? Am I seeing this person really for what it is? And especially when we do telehealth, we have to know what the rules are as far as telehealth and this population. So I'm going to kind of go off on a little tangent here by making sure that when you are giving out consent forms in telehealth, that you do the emergency contact form, and every session you know exactly where your individual is, so that if suicidal thoughts are part of their history, that you know exactly how to get them help if they share with you that this is my plan, and I have full intention on following through with it in the immediate future. That's when I raise my red flag and say, all right, all therapy aside, now it's time to keep you safe and alive. And I explain that to them also on day one. This is where I draw the line. And even though you might not like it in the moment and probably will be angry that I make this choice, but my goal is to keep you safe and alive and of others. So making sure you have full disclosure on your limits of liability and limits of confidentiality can be very helpful on day one. So a lot of times my intake takes 2 sessions, depending on how they present, because I don't want to skip a beat on this at all. And throughout the intake process, I ask for their input. You know, what are your thoughts and reactions about what I just said? And I allow them to contribute to the conversation. I also ask about aggressive and violent behaviors. I also ask about any desire now or in the past to hurt or end anybody else's life. I also ask about any unusual perceptual experiences. Are you seeing, hearing, or feeling things that aren't really there or not perceived by others? That's a very important question to do on your risk assessment, because with the kind of repeated exposure to trauma that these individuals experience, they do have these brief perceptual experiences that are very unusual, and they're very scary. And it's unfortunate that they then consider themselves broken or unfit for duty and think that they have to leave their job. This is just another indicator of stress and the ill management of their internal stress. Their resiliency that they've relied on has a not just a dent in it, you know, something's blown a hole right through it, you know, that shield of armor that they carry. And again, with the right kind of approach, using the right kind of modality, we'll address it. For example, I will speak to an individual and they'll say, yep, rode up on scene. And when I looked, it was a motor vehicle accident. And when I looked inside the car, I saw the same car seat that we have for my child, because it looks like my child is the same age as this one. And as we were taking extracting the individuals from the vehicle, and I was examining the child for a moment, I saw my own child's face right there in front of me. And so we talk about that as scary as that is, that's a normal reaction to high levels of stress, that repeated exposure to trauma. And I encourage you to review the inner workings of the amygdala, the prefrontal cortex, and the hippocampus, because if you do understand how those three interrelate and work together and also can work against one another, you can really educate your clients on how they can better manage their own mental health. And I'm not going to get into all that. On the first slide, or no, I believe on the last slide, one of the last slides is my email. I encourage anyone, if you want to speak more on some of the things that I'm addressing today, please do that. So again, if you feel that you have the skills and the training, even a person with a plan is somebody you can work with, because it's not until they get to the point of intent that you really, everything needs to stay aside. But I wouldn't encourage that unless you've had the right training. Because most first responders, it's quite evident when they need a Baker Act, whether it's voluntary or involuntary. They will, if trust and rapport is formed, they will share with you. And, then of course you got to know what to do next, because what people don't understand about a Baker Act is whether it's voluntary admission or involuntary admission, once you're admitted, you don't get out until a psychiatrist signs you off. And they get psychiatric reviews every 24 hours. So if they're admitted to at midnight, they might have to sit there a whole day, because the psychiatrist has 24 hours to evaluate them. Most facilities will evaluate immediately, or as close to immediately as possible. But there are some facilities that have a high volume, and that it can very well be that length of time before they get seen. So knowing how a Baker Act facility works is very important also. Some individuals, when they go in on a voluntary admission and then are admitted, they think they can leave because they feel better, or they don't want to stay the whole 3 days because, I got shift coming up. Well, it doesn't work that way. And sometimes they feel betrayed. that, well, I went in voluntarily, why can't I just leave? So again, as a clinician, as their advocate, so to speak, you want to educate them if a Baker Act option is something that you might have to consider. Marchman Act, primarily for alcohol and substance use. This is where you have individuals who are performing behaviors of high risk when they're off shift, or drinking or using substances in severe amounts that affect their home life. That's an option. I will say a Marchman Act, though, does not have the same policy as a Baker Act. A Marchman Act is not, I don't know how to explain it, but the psychiatrist doesn't have to sign off. Once they detox, they typically can leave if they're admitted under a Marchman Act. The facility, and correct me if the laws have changed since my time working in a Baker Act facility, but we could never hold anyone that was brought in under a Marchman Act. And I do believe that that's, still the truth. But knowing what it's like, voluntary versus involuntary, knowing if your region or your area has special accommodations for first responders, because 9 times out of 10, if you're dealing with a law enforcement officer and you shuffle them in through the front door, or even when they get back to general population, 9 times out of 10, there's going to be somebody in there that they brought in just a moment ago or last shift or something of that nature. And so we've gone to great lengths to try and talk to facilities to allow special side door entrance and alias if necessary, and that attention be given to the type of care that they need, because the reason for them being there is not the same as any civilian. So knowing, again, what your Baker Act facilities are like, how they function, what goes on the inside is very helpful, I think, to clinicians as far as making the choice of whether to initiate one of those two for a client. I'd really like to ask if there are any questions or comments on what I just covered. If you want to know more or anything else, please feel free. Or if there's something I didn't mention, if you want to add, I think this is a very important topic to know. We have some really well-educated and experienced people on this call. So if you are willing to at least put something in the chat that we can bring forth, unless you'd like to just move on.
I think you covered it very well. Just speaking as a former first responder and as a male, the hardest thing for me was to admit that I needed help. Right. As a police officer, I'm supposed to be this role model, this robot, so to speak, and I think you covered it kind of well. But it was even harder as a man, especially someone supposed to be the head of the household, to come forward and speak. When I did come forward and ask somebody, "Hey, I'm having some issues," law enforcement, this is the kind of the community I was in. It was, "Hey, let's go have a drink." And that's how you kind of handle it. And 1 drink leads to 2 drinks, and that's how you resolve an issue. So I'm really pleased to be part of this class, and it's again, it's opening my eyes, and you covered it very well.
Thank you, because when we do fill these roles, just like you said, I mean, take a look at any law enforcement officer's vehicle. What does it say on the side? To serve and protect. That's what's not only taught to you, but repeatedly pounded in and reinforced. You are responsible for the protection and life of the community. And it's repeated and not allowed to be forgotten. And so when things do go awry and the stress mounts and mistakes are made, which is going to be inherent, of course, it's going to have that kind of level of stress on who am I? Am I effective enough? Do I fit in the role that I've stepped into? Am I really the person that people see me as? And that can be very destructive internally.
Yeah, not only that, but it causes some boundary issues with the home life. You don't, because it's so pounded into your being, your very soul, you don't separate home life from work life. And then you become that person all the time. All I wanted to do was hang around other police officers because they're the only ones that understood me. My wife didn't understand me, my mom, my kids. They didn't understand what I was going through on a daily basis. So there was no separation. There was no switch. I didn't know how to turn it on and off. And so that was a big part too.
Right. Right. And, you know, some of the parenting styles or beliefs that you have because of the job that you do, for example, many first responders refuse to have a pool on their property and refuse to allow their children to go to pool parties, because if they're not there, then nobody can protect their loved ones the same as themselves. And so that's another area of how the stress from work comes home and creates difficulty, because their beliefs about how the world works, it changes. I like to say to first responders repeatedly, you know, your normal is our abnormal, and our normal is your abnormal, or soon seems to be, because your job is all about structure, hierarchy, SOPs, SOGs, and, you know, you're taught and trained repeatedly that, you know, if you do things in this way based on how we've got these protocols, then you will be proficient, if not successful. But in real life, we don't have those. We don't have SOPs and SOGs to, you know, garnish our life.
I do have a question. So with the fire department or the fire rescue, do you see the same? So in law enforcement, there was what we call blue humor, and that's how we dealt with traumatic scenes.
Yeah.
You know, I know it's unfortunate. Please forgive me, guys, when I say this, but you know, if we saw a dead body there, we would joke about it. That's how we kind of dealt with it. Do you see that same thing happening in first responders? You know, fire rescue?
Oh, absolutely, across the board in all areas. And so from a clinician standpoint, one of the things that I was taught early on when I started doing debriefings and, you know, critical incident responses are a few things. If you can't handle the dark humor, because it does get a little, like, you know, a little eyebrow raising sometimes. And if you can't handle the severe profanity, and sometimes very, I don't know how to frame it, but the profanity gets, you know, quite specific. And, you know, you almost can't break through the barrier. So I always said, hey, in my lifetime, I was always the one putting money in the swear jar, and don't always have a filter when it comes to what it is that I need to express out of frustration. You know, it lined me up pretty well because, you know, I didn't take offense to it. And then also understanding that sometimes the five senses, if we take a look at what we see, hear, taste, touch, and smell, that's part of your amygdala doing its work. That's how the sympathetic nervous system takes in its information to decide whether you should freeze, fight, or flight. And knowing that that bit of information from the subconscious is what sticks. And sometimes lack of sleep because they don't want to have that nightmare one more time. They can't handle seeing what, you know, those nightmares portray and in almost a replay of what they go through. And sometimes, again, it's all about just moral injury. They might hear a mother's screams because it's a pediatric code that you're attending. That's what's bothersome, that how distraught the mother was. And so tapping into their five senses, what do you recall when you think of this situation? And the intensity of the sensory response sometimes is what creates that avenue of the emotional pain that they can't get themselves free from. So that's another angle to approach when you're trying to understand what's going on with an individual that might be triggering some suicidal thoughts or morbid ideation or some of these other issues. And you're right, Thomas, pouring a little liquor on these symptoms or even some substances, it works. That's why people do it. And so we have to understand that when we see a first responder and there's, awareness of all these factors, that they are very intricately intertwined. Think of the type A personality. What are they fighting against within themselves? And so that is why these things begin to attack them. So again, just, encouraging any clinician to really know what's the presentation of a type A personality? What does it really look like, sound like, and behave like? Because you're going to then understand their inner coping skills, the internal means of coping versus the external means of coping, and where's the breakdown in that? And again, through much of my time with clients and the treatment modalities that I use, I bring it up. When was the last time you drank? And it becomes part of their therapy to keep track of that. And many times midway through treatment, I'll ask and I get a response, and I can almost predict which number of session it is, just because I use a very structured modality. Right in around session 6, I expect to hear that they haven't drank or haven't had a thought since our last session, and then we talk about that some more, because again, all these things can be addressed and dealt with and recovered from. PTSD can be addressed, corrected, and individuals can recover from it. There's no bigger sadness for me as a clinician to know that a person comes to me and says, I was diagnosed with PTSD 10 years ago, or early on in my career, and I've lived with it since. Or I didn't think there was help for me out there because I was diagnosed with PTSD and I thought I just had to live with it. And us as clinicians, we need to understand, we need to study PTSD if we're going to work with this population. We need to know it inside and out, what it comprises of, what are the cluster of symptoms, because just being exposed to a criterion A event still doesn't get you the diagnosis. We have to understand the 4 subcategories, the cluster of symptoms, and we have to be able to rate the intensity and frequency and how it impacts their life. And then finally, also understanding how they see themselves subjectively, how they see themselves professionally, and how they see themselves socially. Because if there's a major decline in at least 2 of the 3 of those life areas, we're looking at somebody who is at risk for, suicidal action, and we want to address that. So again, working with this population, knowing what questions to ask ahead of time, and maintaining that ability to have these conversations openly, having a voice of confidence, sounding like, whether you're faking it till you make it or not. You know, you got to sound like you know what you're doing and that what you're going to do for this individual is going to help. So the more that you seek out trainings and take classes that help you understand the concept of suicide, the concepts of PTSD, and how to better improve your intake process. You know, what is your biopsychosocial assessment like? And that are you including a full risk assessment? Because all that information, you know, is your best ability to create a profile on this individual. And you have to look at all areas, even back into childhood. And of course, you know, people joke about that because, oh, you know, I've got mommy and daddy issues, or my childhood was this way. So is that why I'm so messed up? Well, you know, it's a plethora of all those factors. Some people can have a very unsettling childhood, but because of the right kind of mentorship or other life experiences, maybe their resiliency in those areas is solid. Maybe somebody who had a great childhood and then starts to experience these things but has never been taught how to cope could falter. I've had a chief of a department ask me point blank if there was a portion on their application that they could include to weed out people that might get PTSD or might have suicidal thoughts. And, you know, I said, well, you know, all of this is PTSD or trauma is part of the job you do. How they're going to react is unique to each individual. Whether they eventually get to the diagnosis of PTSD or struggle with suicidal thoughts is not based on a screening, but, you know, how the department itself functions. Of course, I wasn't the favorite person in the room when I said that to him, but I did follow up after his question with some very strategic plans. And the first one was to establish and put to work a peer support system. Because the backbone, Dr. Adair has said this many times, and I believe it fully, the heart of any true resilient department is peer support. So again, knowing what peer support is in departments and knowing how it functions, how they function, and, you know, do they use it as their SISM approach or not? And how are these things working? Because the departments are so structured with hierarchy and things of that nature, the concept of SISM or having things in place, sometimes they don't take time to review and really find out, is this helping the individual? Because what happens further on down the road isn't necessarily, you know, as soon as the incident happens, they are probably sitting there still trying to, you know, regain baseline to their understanding of what just happened. But 72 hours post-incident, and then of course, 1 month, and then equally 6 months to a year post-incident should be check marks of, are we checking in on these people? Because over time, you know, symptoms grow and intensify. I will later on, you know, remind you the difference between acute stress disorder and PTSD is defined by the first 30 days. And as clinicians, we want to make sure that an individual has 30 days to allow their own natural strengths and resources within them and resiliency to do their work. We don't want to intervene to cut off one's own ability to recover. So allowing a person to struggle, not on a suicidal basis, but allowing a person to struggle for the meanwhile and encourage the emotions, encourage them to express themselves. How did this impact you? You know, what is your thought and belief about what just happened? Those things can be looked at examined and corrected so that they are able to regain the ability to look at their circumstances in a more realistic, balanced way.
So Michelle, I just wanted to make a real quick comment, circle back a little bit to what you said that I thought was very important about explaining the process of going into an inpatient unit. And I think even a step further than that is even explaining that if you are in your local area, chances are you're going to see people who are going to recognize you because you've been involved in calls that have to do with them.
Yes.
And that this is a potential issue and this is a potential thing that you may have to deal with. And their privacy rights as patients when they're in those settings, because I know in the experiences we've had at our facility with some of our local folks, there has always been a push from the departments that when they find out that somebody is there, that they demand information, and we have to advocate and say, no, and you don't have to provide that either. And, you know, we're here for you, not for them. And we have to go through all of that because it is such a foreign environment and it's such a foreign process. And there's already a level of mistrust when somebody is brought in voluntarily. So we have gotten to the point at our facility, because we are the only one in our county currently that is a Baker Act receiving facility, that we offer to our folks when they are identified as first responders to possibly see if they would like to try to transfer to another facility. And we have sister facilities in our surrounding counties that are very, very welcoming and open to that. And we can give them that choice. So to minimize that kind of that additional impact to them.
I'm so grateful that you shared all that, and anybody that does have the inner knowledge of how their facilities work, I would really be grateful if you shared your information with us through email or however else, because, you know, more and more we're going to be reaching individuals throughout the state, and it is likely that I might, you know, encounter somebody in your area or somebody in your close by area. And, you know, if I know you're there and if I know that this is how you operate, then I'm going to bring your facility's name up and encourage that choice as well. And I'm glad that you offer them the choice to be transferred, because that again, says that the purpose of your treatment is based on the client best interests. And yes, the whole HIPAA thing. And if you really want to get me on a soapbox, we can talk about Fit for Duty, but I don't know if we have time for that, because I could probably talk nonstop for 3 hours on Fit for Duty. We're professionals in mental health, and I remind people all the time, mental health is fluid. We can be in deep despair, be calm and content, and be angry as hell all in the same day. Doesn't mean we're unfit. It means that we are allowing the natural part of being a human being to express itself. And when it does clog our own system, when we seem to be persistently in a negative emotional state, well, we can do something about this. And it doesn't have to make you unfit for duty. Again, I'm not going to go into what I think about all that, but if we can teach ourselves how to keep, our systems in check mentally, and not hide behind our struggles and pretend we're doing okay. I mean, I'd rather trust the person that knows how to get help when they need it versus somebody who thinks they can hide behind their symptoms and just put on a face. But we need to make it open and welcome, encouraging. And I do truly believe that clinicians that really do have a spirit for this specialization, that we can do a great good for stigma on PTSD, stigma on suicide, stigma on all the big factors that keep people from getting help. even drug and alcohol abuse, and we all know that, the incredible amount of shame and guilt that goes along with, when a person of this nature doesn't cope as they once did. It's a major decline in how they see themselves. So that subjective part. All right, let's move on.
Thank you, everyone, for that. That was a great conversation and a lot of really good information. Michelle, thank you so much. Such an important. So during the remainder of our time together this morning, we're going to have the opportunity to really jump into some of the brass tacks of the evidence-based practices or evidence-based treatments with the first responder population. But I did want to spend just a few minutes talking about an important piece that we didn't get to in the previous section that I think really kind of ties in some of what we were talking about there towards the end of the conversation before the break, and also this next segment. And it's another part of this survey research that we've done with our first responder population. We've talked a lot about critical incidents and repeated exposure to trauma and potentially traumatic events. And there's really not a standardized way out there to measure what a traumatic event is. As we've been talking about, it can be different for everybody. Florida statutes do actually define what a traumatic event is for a first responder with regard to what makes them eligible for PTSD-related compensation under workers' comp. So there's a list of 12 or 13 different items in that Florida statute that take aim at defining what a critical incident is. We could probably have a lot of discussion and debate on whether or not we think that's a good idea that those are in statute, but they're there. But a critical incident or a traumatic event is very hard to define and capture and measure, but we think it's important to try to do so. So another piece of this screener that we use is something called the Life Events Checklist. And that's a standardized checklist that asks the respondent whether or not they've experienced something in their personal life or as a result of being on the job, like an occupational level exposure. So we thought that life events checklist might be a decent proxy for screening in the number or volume of traumatic events that a first responder may have seen over the course of their career. So this chart here has the event that's on the life events checklist in that first column, the proportion of first responders who responded that they had experienced that particular type of life event in their personal life, and then also whether or not that first responder had experienced that type of life event in their professional life or occupational exposure. And the life events checklist, I think, has maybe 15 or 16 different items. But today we're only going to talk about a few that really kind of rose to the top as being potentially a proxy for some of these critical events. Something like witnessing severe human suffering, sudden violent death, sudden accidental death, serious injury, harm, death caused to somebody else. And as we expected, or as you would hope, a low number of first responders reported experiencing this in their personal life. So that's good. You would hope people just aren't, again, out there in their everyday lives being exposed to people dying a sudden violent death. But first responders in work-related exposure, those numbers were much higher. So a much higher proportion of our first responders are experiencing these things on the job. And so we thought, well, is there any correlation between on-the-job exposure to these types of things and the mental health screeners that we talked about? We went in, we were actually able to do some statistical tests to determine that there was, in fact, a correlation or a statistical relationship between exposure to traumatic events on the job and some of those mental health screeners. So even when we controlled statistically for if somebody experienced this stuff in their personal life, we found that the more likely they were to have experienced this on the job, they were more likely to have one of these mental health concerns. And that's really important because I think there's a lot of conversation and discussion around these things right now, but this is the first research where we were actually able to go in and isolate this and say, yes, Some of this is being contributed to due to the exposure to these potentially traumatic events on the job. And so these were some of the other potentially traumatic events we also looked like: being exposed or running a call where somebody was physically assaulted, where there was an assault with a weapon, where there was a sexual assault. Far less first responders had experienced this in their personal life, thankfully, but far more had that work-related exposure. And again, there was an association between exposure to these types of traumatic events and some of the mental health concerns that we've been discussing. And as I mentioned, the life events checklist has far more items on it for people to choose from, but they did not rise to the level of being significant. And I started thinking to myself, well, why did some of these become significant or become strongly correlated with these mental health screeners, but others didn't? And I thought about it for a long time, and this is my educated guess or my hypothesis at this point. It's not really something we can test, but we do hope to continue to do more research in this area. Is I think, or I suspect, it has something to do with this concept of moral injury. And, Michelle's talked a little bit about this and the importance of addressing this as a clinician in the work that you do with first responders. Because oftentimes the signs and symptoms of moral injury will look very similar to PTSD or depression or anxiety, or maybe driving, some of that harmful substance use, some of those sleep disturbances, etc. So these are incidents where first responders are in situations that are ethically confusing or conflicting, or where they're subjected to events that really challenge our moral compass. And so I think that a lot of what's going on in our responder community is more of a result of moral injury than some of the other potential factors that are in play there. And I do want to point out that third sub-bullet under the third main bullet: being exposed to unethical or unjust behavior within their own organizations or colleagues. Oftentimes we hear that this is the most stressful, impactful, or damaging thing that can happen to a first responder is not the traumatic event itself, but how the agency or how their colleagues handle their response to that traumatic event. And the literature now even supports one of the strongest predictors if somebody will start to develop PTSD is not necessarily the traumatic event they responded to, but how their organization handled the response to that event. And so fortunately, that's something that we can help organizations change. We may or may not be able to change the way somebody responds to stress, although there are some resiliency techniques where we can help individuals be able to work through that. But we definitely can, from an organizational or a cultural level, start to teach organizations and leaders how they respond to these incidents is impactful to their people, and it's important, and it can be one of the strongest predictors of how well their people do after a traumatic event. So I just wanted to take some time to walk through that because I think it's so incredibly important. All right, we will jump back over now to Michelle, and I know we talked about a lot of this already, but is there anything you want to hit on this slide, Michelle, that we didn't focus on yet?
Really, the only thing I'd like to emphasize is the type of treatment modalities that individuals are learning about. I know that there's a wide range of evidence-based modalities. The type of research that really goes into some of these modalities is sometimes, not as high level as we'd like to see it. But again, knowing that the clinician has gone through not just, the 1 day, the 2 day, or even a 5-day training, but they've had some sort of supervision on keeping fidelity to the modality is very important, because that consistency can, you know, really take an individual from struggling to, you know, that regained sense of power and control. So one of the things that I strive to do, again, when I'm building a connection between who I am versus the type of, you know, people that I'm addressing, is knowing what the history or what the department's like. So when I go on ride-alongs, I ask them, you know, like, you know, tell me how the department's, you know, been. How long have you guys been in EMS, you know, fire combination? Or how long's it been since you guys have had professional status instead of a volunteer status? And you know, what is it that you like about your environment, your demographic area that you serve, and what don't you? Again, you know, they enjoy talking about what they experience, because they don't get to talk about it much at home, or choose not to. And there really is nobody that is curious enough to ask. So again, if ride along doesn't seem like the type of thing you're interested in, you know, keep a watch out for community events. I know throughout this week in our community, the different first responder departments are hosting a food drive, the MANA concept, you know, of collecting food and supplies for people that are in need. And so, you know, me knowing about that, I might want to, you know, just kind of walk up and, you know, have myself, you know, introduce myself to someone who appears to be in charge, and, you know, ask their permission, like, hey, you know, do you mind if I help out? You know, do you mind if I stand with you and do stuff like that? So that's another approach. If ride-alongs, if you're just really not sure how to go about that, it's another approach. So good question about modalities. And are we going to have time to go into that more detail, Kelly, or should I do
Yes.
it now?
Yeah, we've got some specific slides coming up that'll address each of
Okay.
those.
So then if you don't mind, I'll answer your question later. So thank you for asking, because I think it's important that people want to expand their abilities. And so thank you. Recognizing coping, I talked about this before. What are their inner coping skills? What do they rely on? You know, that strength-based approach, because that's what a type A personality wants to, and how they thrive. You know, they want to thrive in the way that they used to thrive, and sometimes they've just kind of forgotten what it is. And maybe some discussion on why all of a sudden it didn't work for them. You know, why was this way of coping all of a sudden no longer useful? The concept of dark humor is a very important coping mechanism. I encourage it wholeheartedly. However, when I do speak with individuals and peer support teams, I also ask them to recognize a person that may have engaged in dark humor and no longer is, or seems to have maybe an irritable reaction to some dark humor when before that wasn't. It could very well be that what is being said via the dark humor might just be hitting too close to home. And if there's one thing that in any first responder department that exists, is that you know, if they pick on you, they love you. And sometimes, you know, the hazing and teasing and stuff of that nature can really keep people from saying things out loud that they really wish that they could, because they'll just turn it into a joke, or they'll dismiss it, or they won't take me seriously, because it's all combined in with that dark humor. So watch for that as well. Watch for how they're reacting to the dark humor. So first and foremost, when we go to diagnose, especially with this population in this structure, I encourage everyone to go to the VA website. They offer a training. I don't believe it's free, but I don't believe it's expensive either. It's the CAPS-5 training, and which is the clinician administered PTSD screening, I believe. And it's a 5-item or a very large 5 distinguished items test. If you can understand how to accurately diagnose PTSD, and that is the diagnostic tool, please do that training for yourself. It will educate you a lot more on how PTSD starts, how it manifests, and how it impacts an individual's life. And that type of screening, if you're able to do that during one of your sessions, can tell a more accurate picture of how the person is suffering. Secondary to the CAPS-5 diagnostic tool for PTSD is the PCL-5. That's more of an indicator because there's a threshold of either you either it indicates probable PTSD or unlikely that it's PTSD. And I like to use that PCL-5 and kind of like show it to them and say, look, we can measure these symptoms in intensity and severity. And if we can address these symptoms to reduce severity and frequency, think about what that would be like if you could even eliminate them, you know, and get them to understand, again, that PTSD is not something they have to wear as a you know, a scarlet letter at all. Because I remind them, you know, they've all seen trauma. They all have stress from it, and that stuff occurs after the fact. Whether or not they get to the actual disorder is different, because I like to encourage post-traumatic growth as well. We can grow from this, and this doesn't have to be debilitating. And sometimes it just really blows their mind. Like, really? Like, why haven't I heard this before? And so, again, I like to encourage clinicians to be better ambassadors about what we know about PTSD and what we can do with it. I myself have been trained in 2 very highly effective modalities, one being exposure therapy. That is the primary therapy that is engaged at UCF Restores. So if you're over there in the Orlando area, I encourage you to do a lot of research behind what UCF Restores is. Won't go into it just for time frame, but they have what's called TMT, trauma management therapy. And I also believe that they offer training for clinicians. Again, I don't know price and anything of that nature offhand, but it is on their website. And they are a great resource, and they're a free resource. So if you encounter an individual that either can't afford your services or you don't have their insurance, please start utilizing UCF Restores. If that, of course, is something that is close by. And even if it's not close by, they offer great free options for the individual. You know, as clinicians and early on in my career, of course, you know, we have all these theories, right? You know, all the theories out there that we study, and each theory has its set of skills that they encourage us to do to incorporate progress, or to show progress utilizing that theory, that approach. And I think because our profession is very young, I'd like to see just even licensure be had at a higher level, whether that's more education or, you know, more a more maybe structured internship to where you are encouraged to do more of the certification process. I think that being informed and working with this population isn't enough. I think taking on the ability to certify yourself, and we'll go over the common ones, but I think it takes you from being a good clinician to an effective clinician.
Michelle, sorry about the slide sorting there. I'm gonna jump around a little bit. So I'm
Okay.
I'm gonna jump to this next one right here.
Okay,
and
good. Good. So on here, this is a lot of what was being mentioned. So when a person comes to you for help, keeping in mind it's, not usually about the critical incident or the call itself, but more like the work environment or the home environment. Of course, finances and stress that is accumulated from all life areas compounds it all. So sometimes it's behavioral activation that we want to be able to do. And again, behavioral activation is part of the trauma management therapy that UCF does teach. And basically, with behavioral activation, you take a look at different life areas, your family relationships, your social relationships, your professional or career choices, your enjoyable activities or recreation, spirituality or religion, volunteerism, the general concept of just responsibility. And what you do is you draw out, what's your understanding of, for example, in your intimate relationship, what do you value about this relationship? And you encourage them to actually identify what their values are. And then you take a look at, all right, so can you tell me how you demonstrate this as a value on a regular basis, whether it be daily, weekly, monthly, or periodically? And you really encourage the individual to take a look at how do they demonstrate what they value? What does that look like on their daily basis? So something measurable, an action. And then you also want to rate its importance and its enjoyment. So then here we are allowing the person to create balance in their life. Yep. In my intimate relationship, I have, things that I do that are important and things that I do that are enjoyable. Not everything has to be important. Not everything has to be enjoyable. But if they contribute to what you value, you're living that balanced life. And then taking a long, hard look at maybe it's been a while since you've done something about, this value. Maybe some of your activities aren't showing up as often as you think. And then all of a sudden, you've given them momentum. Sleep hygiene. If there's anything that's going to destroy someone's ability to have a clear mind and balanced mental health, it's lack of sleep, which is inherent in these professions because of shift work, because of how they rotate. And, most emergencies happen either, from 5 o'clock at night to 5 in the morning, or at very inopportune times. So the disruption of sleep cycle and that circadian rhythm, can sometimes be exactly what that person needs to get back on track and be resilient once again. Anger management, the refusal to identify any other emotions that might be going on, a sense of betrayal, sadness, deep sadness, because of what's going on, or a sense of isolation or inappropriate communication between home and self and work, or angry even at their job for the demands that are placed on them, the mandatory overtime. Once again, they're going to miss out on something family oriented, and family is very important. Exposure therapy, highly effective. It is no walk in the park, requires a lot of training to do. And again, UCF Restores has done a lot of research to back up its efficacy. I believe their latest stats are that of those that are involved in their trauma management therapy, I think it's 78% or even higher now. I don't recall their latest, you might know, Kelly, but it eliminates PTSD. People leave their treatment without PTSD, and they have a 3-week intensive program, all paid for. The only thing the individual needs to do is create the ability to be there every day, Monday through Friday. The hotel's paid for. They have to provide their own food, but you know, it's also augmented by virtual reality to enhance the scene. Cognitive processing therapy, another, and that's my prime modality, is the cognitive processing therapy, because exposure therapy can't always be done in a 50-minute session. It can have that variation, but the efficacy of the outcome doesn't show it to be as effective as the exposure therapy in its truest form. Now, the exposure therapy at UCF Restorers is not prolonged exposure. It's different. There are subtle differences to that. So I do want to put that out there. Cognitive processing therapy has been equally as researched and has the evidence behind it. It was developed by doctoral level clinicians at the VA. It is one where you can do some online work. There's a course to take, and then supervision. And it also addresses very effectively PTSD. That's primarily what it was designed for, and also helps with suicidal ideation. So those are the two modalities that I always have my rubber stamp on. EMDR is also something that does have research behind it. It's recognized by SAMHSA. I do believe, from what I've read and what I've heard from colleagues, is that the level of research behind it isn't optimal. But I've also known plenty of people that have engaged in EMDR and have had great success. So knowing your client and knowing what modality is going to best suit them can also be very important, as well as DBT and CBT. But CBT without a specific skill set ends up, more often than not, just being talk therapy. And for this level of clientele, talk therapy is not enough. They already are talking to some degree, whether it's with their coworkers or somebody who they trust. I find that when a first responder comes to me for counseling, they want to do more than just talk. They want to know they're making progress. So I don't know if I can tag on now the assessments that I use on a regular basis, if that's okay. One of the things that I do, along with sending consent forms, is I automatically give them the PCL-5, the PHQ-9, the GAD-7, the audit for alcohol screening, and the DAST. And I pile that in along with their consent forms because it makes it seem like it's part of the intake process. I take a look at those assessments. I discuss with them what those assessments mean during our first session. If there's an indicator that there's probable PTSD, then doing the CAPS-5. If and I will say it's not always necessary, but sometimes from a legal standpoint, if there's an indicator that there's a legal issue surrounding the first responder, then I do incorporate the CAPS-5, because that is the diagnostic tool. And if I'm ever going to be called upon in a legal fashion, I want to make sure that I have all my strings tied and come with a full set of professional charting and reporting. So I go over all those self-assessments with them, and then midway through, I repeat the assessments that I deem most necessary. So usually the PCL-5. If there's suicidal ideation present, I'll add in the PHQ-9. And then, of course, if there's drinking, I'll add in the audit. And then not always, but most times I can get them to do a third set of assessments, because by end of treatment, or what we deem to be end of treatment process, which again is why I like cognitive processing therapy, because there's a beginning, there's a middle, and there's an end. And it encourages repeated assessments to show progress. And it also helps you understand where maybe there isn't progress that they might not be telling you about. And if you don't catch it, then, you know, keeping PTSD and suicidal thoughts in remission can be missed. So I do a beginning, a middle, and an end set of assessments. And that tells me more objective data about how a person's doing. And sometimes, you know, I actually have to prove to the individual, hey, you don't meet the criteria any longer for PTSD. You are good to go. Sometimes they want to hang on to that for whatever reason. And I say, you know, hey, that's up to you. Some military, you know, get concerned that I'm going to take away their benefits. I don't deal with military currently, but did in the past. And I say, oh, no, I don't report this to anyone, but this is for you. You get to live this lifestyle. Nobody else has to know what it is or what it isn't. But I just like to stress that having a structure, giving them homework, understanding that part of the adaptability to living a better life without these symptoms is some kind of homework, some kind of intervention that can be practiced in short intervals. Because if they are practicing in short intervals, such as daily, they are naturally interrupting that negative thought cycle by doing that skill. So if you assign it daily and tell them it must be done daily to be effective, they're doing themselves a favor. It's not just learning the skill, it's also interrupting that negative thought cycle and replacing it with something more realistic and balanced. And whereas if they wait till maybe a day or so before the next session and they do 7 of them, that's not creating that interruption. So therefore progress is slower. And I explain that to them over and over and over again, that their commitment to what we work on means daily practice. And again, it's not about the skill, it's about creating an opportunity for them to learn new brain pathways so that their reaction to these memories and reminders starts to become different, because that's what they're seeking.
And Michelle, I just wanted to mention too, we've mentioned it a couple times and we don't have a lot of time to talk about it on the call today, but I'm going to drop in the chat the link to the PTSD workers' compensation legislation, because that is so important when you were talking about assessment and diagnosis and documentation. Just any clinician who's working with this population to know that that is one pathway or one avenue. We hope that we're able to do prevention and early intervention and treatment so that way our first responders don't need to utilize, PTSD workers' compensation legislation. But if they do need that, then it is there and it is available. And the provider would want to make sure whatever it is that they're doing is in alignment with the requirements for that law. So I'll just drop that in the chat in case anybody's interested in learning more about what that entails.
Awesome. And I would even say, if there's any clinicians out there that use Simple Practice, if you align your, your treatment plan accordingly, cognitive processing therapy is embedded in Simple Practice. And it helps you, again, verify that what you're doing has merit. So here, other interventions that work. Not everybody's going to have PTSD, right? And, of course, we want to make sure that we have that well covered, because that's the worst part of, being encountering these individuals and not being prepared. But here are a whole bunch of other things too that we can do in the meantime. So remember what I said, the first 30 days of after experiencing a trauma, we only have acute stress disorder. That's the accurate diagnosis. It's 30 days plus when PTSD can be involved. So, you know, what can we do in the meantime? So we can encourage the trauma responses. I remind people that compartmentalization was necessary and definitely useful for getting through the moment, but continued compartmentalization, or better known as escape and avoidance of the reminders, will actually lead them to a PTSD diagnosis. And so if they can allow themselves that natural process of experiencing the emotions, allowing themselves to acknowledge their thoughts, examine them so that they can be corrected. You know, is there emotional reasoning going on? Are they jumping to conclusions? Is it rationalizing or justifying something? Because all those patterns of problematic thinking lead to self-destructive behavior. So if we can identify if that's going on earlier and allow the person to correct themselves, then we're helping them stay far away from PTSD. I also talk about the adrenaline dump and that to also help them maintain stress levels, because it's not just adrenaline, it's adrenaline, cortisol, and norepinephrine. And that every time that they're alerted, the brain is going to do its job and emit those chemicals. So, you know, understanding what they need to do for themselves as far as nutrition, hydration, nutrients, exercise, the ability to relax. You know, we sometimes when we talk about sleep hygiene, we talk about tactical napping, just giving yourself a blank space of no stimuli on any form. Closing those eyes for 15-20 minutes can be restorative. You know, and things of that nature.
So Michelle, the rest of these slides, I believe, are just going into more detail on the different modalities that you touched on. So I'll just go ahead and click through the slide, and you can follow up or add anything in that you didn't mention already, if that works. Okay.
Yes. So again, cognitive behavioral therapy, that's, you know, kind of the, you know, the go-to. It's the one that we all learn very, very well. And it's good at being able to examine the relationship between their thought, feelings, and behaviors. And actually, cognitive processing therapy is a CBT-based modality. So it does incorporate, you know, the A, the B, the C structure, you know, event, belief, emotional consequence. And so, you know, if you're able to also understand where the unhealthy patterns are lying, and utilize motivational interviewing to get them to see the difference between the way they see themselves and how they value their life versus how they're actually behaving, and get them to come to their own conclusion. Because I like to also remind people when I teach peer support that even though a person's struggling and might be struggling terribly, they're still effective. They're still able to be a productive person. They just have lost their way. And sometimes taking them back and reminding them what works. Another modality that I like to use, especially with if alcohol or substances are involved, it's the getting motivated to change, which is also another modality that has a lot of research behind it, but it's very brief. And so I will, you know, filter that in if alcohol use is a problem. So cognitive processing therapy, if done according to the structure, is 12 sessions. It involves, again, a high level of homework, and it gives the clinician many ways to help guide and encourage evaluating problematic thoughts and beliefs that one has incorporated. since experiencing the trauma. The hard part about this, though, that and with exposure therapy is you do have to narrow down their sentinel event. And it's not the worst event. It's not that. It's the event that impacted them the most. So those are two very different conversations. So in order, and they'll argue with you, well, it's the, repeated stuff. It's this, it's that. It's more than just this one event. And you have to encourage them to understand that PTSD only occurs due to one event. It amplifies and intensifies because of the repetition and the accumulative stress, for sure. But you don't get PTSD over and over and over again. It occurs once. And everything else that is then vacuumed into that sentinel event, you will find that their coping mechanism for anything else that has happened is very similar. So that is why if you can narrow down that sentinel event, again, it's not the worst event, it's the event that impacted them the most. And I like to ask them, so what is it that you have nightmares about? What do you dream about? What do you wish I never ask you about that you hopefully don't ever have to address? What is it that you drive 5 miles out of the way to, not encounter because you were on a scene at a specific part of the road and that road happens to be how you get to work? That's probably what's going on. And it could stem from childhood, it could stem from work, it could stem from nothing other than the fact that, they don't understand, where it has evolved. So you as a clinician have to really understand the life events checklist. You really have to understand how to narrow it down so that we can start from the beginning. And again, what you find is that as you address those symptoms when they first, or the coping skills from the symptoms when they first occurred, that you are going to naturally incorporate everything else that's happened to them as well. And they seem to dominate all these events because it's not about reacting differently. You typically don't. Coping skills, because we're habitual and a repeated type being, we tend to cope the same way every single time we consider ourselves attacked. Again, trauma management therapy, it is very intense. Lots of training goes into learning how to be effective. The client, as it is in exposure therapy, what you want to encourage is them experiencing the distress. And what I mean by that is you don't want to comfort them, which is sometimes against our nature to comfort people when they're in distress. But allowing everything to exhibit itself the way the body and the brain require is exactly how the body and brain reteaches itself that this is an event that now is in the past. It's not happening again. It seems like it's happening again because the 5 senses, the amygdala from the reminders are being triggered again. We need to process it in such a way that the hippocampus takes it and puts it and files it as a past event. But escape and avoidance is what keeps us or any individual from doing that. So again, being a provider of TMT is something that necessitates a lot of training and a lot of supervision. Dialectical behavioral therapy, again, it's a highly structured form of CBT. I know that they have different ways that you can access how to do DBT, but again, I encourage, if you're going to use these skills, use them to the fullest extent. It's a major financial commitment, but if you are able to dominate one of these modalities and be highly effective, this is not the type of individual that is going to wait months and months or even years and years to feel progress, or feel better. They want it as short as possible so they can deem themselves good again and go back to their life. Mindfulness, a great anti-anxiety approach. So many of these people that live the life of a first responder have incredible hypervigilance, not being able to go in public without their back against the wall, or some other type behavior that isn't always family friendly, because maybe if they go to an auditorium to see their son or daughter at a school function, they're not able to sit down in the general seating area. They have to stand by the door, or they have to stand way back, and it impacts the family. Families don't sit together during these events, or the child sees their parent at the back of the room and thinks they don't want to be there. So teaching mindfulness, how to be present in your moment and understand the difference between being cautious and being hypervigilant, can really aid an individual to be able to be a part of their family in a way they truly want to be. So again, being a clinician addressing first responders, you have to have a little bit of a backbone. You have to be willing to challenge the person, even despite their best thinking, because again, they're type A personalities. I don't take anger or irritability personally. I work very hard at building the rapport. I tell them ahead of time, again, during the treatment planning, skill building, initial intake process, I tell them part of my job is to challenge you, and I'm going to challenge you. I'm not going to force you, but I'm going to challenge you, because I want you to be able to make a shift based on what you think and believe now versus how you're able to think and believe in a different way that might actually help you. Because then I give them the example, has anybody ever told you to just stop being angry? It doesn't work, does it? But if we know how to control our thoughts and beliefs about what we experience, ourselves, other people, and the world, we're going to be able to balance our thoughts out. And once we balance our thoughts out and our beliefs, our emotions tend to follow suit. And that's how you control your emotions, by recognizing, for example, what are all the variables? How was I involved, but what other variables were going on? Am I making my assumption something that is possible or likely? Am I putting too much emphasis and making it likely that it'll happen when in actuality it's only probable that it would happen? And so maybe we can find some relief there, because the statistics say that no, your family's not going to have a motor vehicle accident. So therefore, you do not have to be hypervigilant about your family members driving when you're on shift. And so allowing them, again, to examine and restructure their thoughts is going to bring down that stress and anxiety. Here we have some websites if you are interested in some of these modalities and would like to learn more. Here's some links that you guys can either screenshot or quickly write down. I also want to say that, again, and I mentioned it earlier, if you guys have any questions or want any insight about situations or modalities or anything, please email me, reach out. I really want there to be individuals out there that are willing to go the extra mile, educate themselves, be willing to form, our own network, our own alliance, because these people are dying, and they're dying because of the things they see and do, and that's not okay.
All right, we're kind of starting to wrap up here. I'm curious if anybody has any thoughts or any comments, questions about either the cultural competency piece, the needs assessment piece. I mean, I think Michelle just did a great job of putting a cap on that perfectly with her last statement. You know, that there's a lot of suffering and death happening among our first responder population that's attributable to the work that they're doing and what they're seeing on the job, these occupational exposures. And so really, I feel an ethical and a moral obligation to do everything I can to be making strides towards mitigating some of that. So just kind of want to open up the floor now for questions, comments, concerns.
Well, I just want to say thank you guys for doing this because I think it's really important and hopefully you can continue to do that exponentially and reach more and more folks. I think it would be beneficial even to expose our clinicians in training as they're going through their educational process to help them figure out where they want to go. You know, unfortunately, some of us are in the field for a long time before we realize, you know, where we kind of fit and what the best thing is. And I think exposure to any of this is really important, and developing the most competent clinicians that we can to serve any population is really in everybody's best interest.
Absolutely. Thank you, Valerie.
And just a side note, it is really fun to ride in police cars and fire engines. It's a job perk.
And sometimes they have
agree.
cool puppies that you can play with.
Yes. Yep, absolutely. Or climb ladders and be in buckets and fun stuff.
So I just wanted to say thank you as well. This has been really great information, and I really am excited about diving deeper into this. I knew when I came in that it was something I definitely wanted to look at and pursue, but getting this information and the resources that you all are providing, I definitely want to dig in deeper. There is a training that I'm doing next month in July that is with law enforcement. And that's like full day training. And then a part of that is the 10 hours of ride along that you mentioned. So thank you. This has really been really good. And I do plan to follow up with probably a few of you after all of this is after I get some things done. So thank you.
And I would encourage you to follow us on social media, because every kind of event that we sponsor and provide, not all of them are appropriate for clinicians, but I think Dr. O'Dare would agree that, you know, if you want to learn more and be a part of some of the events that we're able to provide, you know, in the community, we welcome that.
Thank you.
Absolutely. And thank you, Janice. We're excited to hear that you're attending that training. I heard that the first one went amazing, so I have a high expectation that the next one will go just as well. So I'm excited for that for you.
Yeah, I'm looking forward to it.
On our screen here is our link to our website and a QR code that'll get you to where you can download our app and take a look at our app. We're constantly trying to update it and develop it and make it better and make some improvements and enhancements. So please, as Michelle mentioned, if you have social media, follow us on social media. It's actually, we've learned that it's one of the best ways to reach our first responder population and clinicians too. So we spend a good deal of effort in creating content and sharing content on social media. Here are our email addresses for follow-up. Please feel free to reach out. And again, we're incredibly grateful. We know for everybody, really, time is money and it's so valuable. And so pretty much spending your entire morning with us on a Friday morning is a great deal. So thank you for that. And one final ask, if you would be so kind, please, as to do a very quick evaluation of the class this morning. We do take your feedback very seriously. You can scan this QR code Or in just a moment, I will drop this link in the chat because it's not clickable, but I have to exit my screen share to drop it in the chat. So I'll give you just another minute here to scan the QR code if you'd prefer to fill it out that way. But if not, in just a minute here, I will also drop the link